Hello all. Today we are going to discuss about coxa vara. First of all, you can see introduction. Coxa vara is a progressive decrease in the angle between the femoral neck and shaft less than 120 degrees. The normal angle 120 to 135 degrees. Coxa vara is often bilateral, a progressive shortening of the limb. So this is the picture of coxa vara. The normal angle is between 120 degree to 130 degree. When the condition, the angle will be less than 120 degree. Then we can see about epidemiology. Coxa vara is relatively rare condition. Incidence ranging from 1 per 13,000 population to 1 per 25,000 population. Bilateral involvement seems to occur only half as often as unilateral involvement. No clear pattern of inheritance, but familial involvement in a number of cases has suggested an autosomal dominant genetic pattern of transmission. Next, classification. In classification, first we can say about idiopathic. Idiopathic means unknown cause. So here, congenital, mild or severe coxa vara with associated short or bowed femur. Developmental, progressive, usually appearing between the ages of 2 and 6 years. Rachitic, usually associated with active rickets. Adolescent, secondary to slipped capital femoral epiphysis. Then traumatic, usually following fracture of the femoral neck, rare in children. Then inflammatory, secondary to tuberculosis or other infection. Then secondary to other underlying bone disease such as osteogenesis imperfecta, cretinism, dyschondroplasia, Paget's disease, osteoporosis. Capital coxa vara occasionally seen in severe osteoarthritis and Lick-Beth's disease. Etiology of congenital coxa vara. The exact cause of congenital coxa vara remains unknown. Many hypotheses have been proposed. Mechanical intrauterine stress affecting hip development, avascular necrosis involving proximal femoral physis or head and neck, and metabolic or endocrine abnormalities causing deficit or a delay in normal ossification process. Next we can see about pathophysiology. Abnormal development of proximal femoral cartilaginous physis. Microscopically, tissue in this defect consists of cartilage with irregular cell arrangement and ossification within it is atypical. Metaphyseal bone is osteoporotic. Its tubercula begin atrophic. When walking is begun, the forces that the femoral neck must withstand are increased, and because the neck is weak, varus deformity gradually develops. Presentation. Affecting children, generally present between 1 to 6 years of age, usually present with gait abnormalities, lip unilateral, Wedling joint bilateral. The Tendelberg sign is commonly elicited in the affected hip or hips. Shortening of limb, trochanter is displaced upward, decreased rotation and abduction of hip. Pain, stiffness and flexion contraction. So this is the picture. Then we can see the picture. In this picture, abduction at the hip joint viewed from behind. Normally, when the weight is borne on one, example the right limb, during the tense phase of walking, the pelvis tends to sag on the free or swing the left side because of gravity. This is counteracted by abduction of the hip on the stance right side, chiefly by strong contraction of the right gluteus medius, which acts on pelvis from a fixed femur when abduction of the right hip is interfered with on the supported side, positive Tenderberg sign. Then non-surgical method including spica cast immobilization and skeletal pin traction with bed rest with generally unsatisfactory results. Surgical management. The treatment of choice is subtraumatic osteotomy. Surgery can be delayed until the child is 4 or 5 years old. Make internal fixation easier. Indications. Femoral neck shaft angle less than 90 to 100 degrees. Hilgerner's epiphyseal angle greater than 45 to 60 degrees. Documented decrease in femoral neck shaft angle. Tenderberg gait. The subtrochanteric osteotomy is fixed internally with either a blade plate or screw and plate combination, although biomechanically this may provide enough rich internal fixation to eliminate the need for post-operative immobilization. A spica cast can be worn until union is complete. Post-operative care. The cast is removed at 8 to 12 weeks when radiographic union of the osteotomy has occurred. Regular follow-ups included assessment of possible recurrence of the deformity and development of progressive limb length dispensy. Then complications. Reoccurrence of proximal femur varus deformity. Premature facial closure related to facial injury at the time of surgery. Greater trochanteric overgrowth associated acetabular dysplasia, pseudoarthrosis, avascular necrosis, leg length discrepancy and degenerative arthritis. Thank you.